Hi all, this is Dr. Reshmi. In this video, we are going to see about ascites. Introduction. Ascites is derived from the Greek word ascitos, meaning bladder or belly bag. Ascites is defined as excessive collection of free fluid in the peritoneal cavity. Ascites is an important physical sign and its presence warrants a complete and thorough examination and investigation for its cause. Causes and associated conditions. So when the cause is venous hypertension, the associated conditions are cirrhosis and portal hypertension, congestive cardiac failure, constrictive pericarditis, hepatic venous outflow obstruction. When the cause is hypoalbuminemia, the associated conditions may be malnutrition, nephrotic syndrome, and protein losing enteropathy. When the cause is malignancy, the associated conditions can be secondary carcinomatosis and primary mesothelioma. When the cause is infections, the associated conditions will be bacterial peritonitis, tuberculous ascites, and fungal peritonitis. The other causes will be systemic lupus erythematosus, ovarian disease, pancreatic ascites, myxedema, and sarcoidosis. Pathogenesis. Inadequate intravascular volume leads to avid salt and water retention leading to ascites. There is also an activation of the renin-angiotensin-aldosterone system and the sympathetic system which further contributes to salt and water retention. Reduced colloid oncotic pressure secondary to hypoalbuminemia is also an important contributor, especially in states such as nephrosis, malnutrition, and protein-losing enteropathy. Infections, especially tuberculosis, account for an active peritoneal exudation resulting in ascites. Clinical presentation. The volume of fluid collected determines the symptoms. Small amount of ascites are undetectable on clinical examination and are only diagnosed on ultrasound or CT abdomen. Mild to moderate ascites may go completely unnoticed by the patient and detected by the physician on clinical examination by bulging of the flanks, shifting dullness and fluid thrill will also be present. Larger amount of ascites give rise to abdominal distension, increase in abdominal girth, abdominal discomfort and pain. Paraumbilical hernia may appear. Patients with tense ascites may complain of breathlessness due to elevation of diaphragm. An accompanying pleural effusion can be seen. Presence of history of dyspnea, palpitations, orthopnea, paroxysmal nocturnal dyspnea, and ankle edema suggest a cardiovascular disease. History of alcohol intake, jaundice, blood transfusions, IV drug abuse, and upper gastrointestinal bleed suggest chronic liver disease. Ascites in the presence of anorexia, gross cachexia, and weight loss may point to a malignancy. History of drug abuse along with features of malnutrition suggests hypoalbuminemia. History of fever with ascites suggests an infective etiology. Presence of jaundice, parotid enlargement, spider angiomas, gynecomastia, and testicular atrophy suggests liver failure. Presence of engorged veins, raised JVP, sacral edema, and hepatomegaly should prompt a detailed cardiovascular examination. Signs of malnutrition may be present. Facial puffiness and periorbital edema should alert possibility of nephrosis. Classification of ascites. Here we have transudative ascites as well as exudative ascites. Now we'll see the causes of transudative ascites. They are cirrhosis, portal hypertension, congestive heart failure, nephrotic syndrome, hypoalbuminemia, Meigs syndrome, constrictive pericarditis, systemic lupus erythematosus, and myxedema. Exudative ascites, the causes are bacterial peritonitis, tuberculous ascites, malignant ascites, pancreatic ascites, constrictive pericarditis, and overuse of diuretics. Investigations. A diagnostic paracentesis for ascitic fluid analysis should be done. Gross examination should be done to look for color and turbidity of ascitic fluid. It is clear, it can be straw colored, and it can be turbid in bacterial peritonitis. Hemorrhagic is seen in malignant and tuberculous ascites. It can also be mucinous. Cytology. In cytology, total cell count, differential cell count, special staining for malignant cells, gram staining, and acid-fast bacilli staining is usually done. So in culture, bacterial culture and fungal cultures should be done when indicated. Biochemistry. In biochemistry, specific gravity, sugar, total ascitic fluid protein, or ascitic fluid albumin should be seen, and also triglycerides should be checked for. Others, hemoglobin with ESR indicates the presence of infection, urine analysis to detect proteinuria in nephrosis, chest x-ray for cardiac size evaluation and pulmonary tuberculosis, renal and liver function tests should be done, ultrasound or CT abdomen with Doppler, echocardiograms should be done, ascitic adenosine deaminase and atrial natriuretic factor when indicated. Management should be based on the etiology. Bed rest should be offered. Salt restriction in diet, especially in transudative ascites. Diuretics should be given. In case of large or tense ascites, large volume paracentesis should be done. Thank you. Please like, share and subscribe if you like this video.